All right, we'll go ahead and get started. So hello and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or as we call it, the MINSCIMS for short. Thank you to everybody for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injuries. Next slide, please, Anne. MINSCIMS represents an exciting new partnership among the following institutions: Courage Kenny Rehabilitation Institute, Minneapolis, the Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota, also in Minneapolis. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up to Stand Up to Cure Paralysis, the Paralyzed Veterans of America, the United Spinal Association, and the North American Spinal Cord Injury Consortium, or NASCIC. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency and medical services, acute care services, acute rehabilitation services, and post-acute services. My name is Dr. Kimberly Mondin, and I will be the moderator of today's session. I'm an assistant professor in the Department of Rehabilitation Medicine at the University of Minnesota Medical School, and I'm co-project director of the MINSCIMS with Dr. Leslie Morse. Next slide. So a few housekeeping rules to start. The University of Minnesota has organized a CME for today's webinar. So please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the chat and Q&A functions. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly, who will be monitoring the discussion. Next slide. The title of today's presentation is The Effects of Cognitive Multisensory Rehabilitation on Neuropathic Pain and Sensory Motor Function in Adults with Spinal Cord Injury. And the speaker for today's webinar is Dr. Anne Vandewinkle. Dr. Vandewinkle is an assistant professor in the divisions of physical therapy and rehabilitation science in the Department of Rehabilitation Medicine at the University of Minnesota Medical School. She is also the director of the Brain, Body, Mind Laboratory at the University of Minnesota. The focus of Dr. Vandewinkle's lab is to investigate the brain mechanisms of how body awareness in physical therapy, as well as mind and body approaches, may work to improve the daily lives of people with chronic diseases and chronic pain. This focus has led her to investigate a physical therapy sensory motor rehabilitation treatment, Cognitive Multisensory Rehabilitation, or CMR, for sensory motor recovery and relief of neuropathic pain. This year, Dr. Vandewinkle was awarded a Paralyzed Veterans of America grant to investigate brain mechanisms underlying CMR versus adaptive fitness in adults with spinal cord injury. Today, she is presenting the results of a clinical trial funded by the University of Minnesota Medical School, in which she investigated the effects of cognitive multisensory rehabilitation, or CMR, on neuropathic pain relief in adults with SCI-related neuropathic pain, called The Effects of Cognitive Multisensory Rehabilitation on Neuropathic Pain and Sensory Motor Function in Adults with SCI. Dr. Vandewinkle, welcome and thank you for presenting.
Thank you, Dr. Mondin, and thank you everyone for being here. I would like to start with the disclosures. So as Dr. Mondin expressed, the study was funded by a 500,000 grant from the Academic Investment Research Program, or AIRP, funded by the University of Minnesota Medical School. And I'm a co-PI on this grant with Dr. Leslie Morse, and I do not have any conflict of interest. And so before I explain the background and the results of this study, I would briefly like to put it into context, in a broader context of this lab research line. So Dr. Mondan did introduce that already, but I am the director of the Brain Body Mind Lab, and one of the main research lines is to investigate brain mechanisms of interventions that improve body awareness, and more specifically, mind-body approaches such as Qigong or physical therapy interventions such as Cognitive Multisensory Rehabilitation, that I will abbreviate as CMR going forward. And so the past and ongoing studies in my lab have been to investigate those interventions for relief of pain in adults with chronic low back pain and spinal cord injury, and also to look at improvements of sensorimotor function in adults with stroke and adults with spinal cord injury. And so today I'm very happy to present the study, the pilot RCT on CMR for pain relief and sensorimotor function in adults with spinal cord injury. So then some background on the study. As you all might know, about 300,000 Americans with spinal cord injury have reduced or complete loss of sensation and movements, and they also lose awareness of where the body is in space. And you might, if you don't have a spinal cord injury, you might have experienced a little bit of that when your foot is sleeping, that you don't really know where the foot is in space. And one of our participants in the study expressed it as that person had paraplegia, so the legs were paralyzed. And she expressed it as, it's as if I'm living from the waist up. And on top of that, about 50% of adults with spinal cord injury have neuropathic pain, and that is often debilitating nerve pain that is burning or electric. And current treatments, especially medication, are not always helping reduce that pain. So before I go further, I just wanted to define the body awareness here in the study. And I define it as the generation of conscious awareness of the state of the body, can be internal or senses or position sense, where the body parts are in space and related to each other. And especially in the brain, there is a part of the brain that is designing a visual spatial body map. So it's drawing a body map in space at each moment in time to guide movements. And so that is also part of this whole body awareness. And because the study is doing brain imaging, I wanted to give you a high level overview of the sensory motor circle. So how sensory function relates to body awareness, relates to movement. So in the next few slides, I will go over that. So imagine you are, it's night and you are thirsty and you want to get a drink in the kitchen, and you walk to the living room and it's dark. And one of your pets or your kids have left a toy on the floor and you're stepping with your foot on that toy. Then the sole of your foot is going to give information, cells that touch the object and cells that don't touch the object, and send that sensory information to the to the primary somatosensory cortex. So that is the area that integrates information from a certain body part, and all body parts are represented in that area. And then that information is sent to two areas on the bottom of that strip of the primary somatosensory cortex, and that is called the secondary somatosensory cortex, and that is located in what we call the parietal operculum. And the parietal operculum has 4 areas, and I'm interested in OP1, the first part, and the fourth part, OP1 and OP4. And then next to that parietal operculum is another area a little bit deeper in the brain called the insula. And both of those areas are key in creating and generating this whole body awareness. So it's not just what you feel in the foot, but how did you already engage your whole body weight on that foot? How is the rest of your body in relationship to that foot? And important for this study, we also found that those 2 areas, parietal operculum and insula, are also key areas in the brain for pain perception. So the link of that will come later. So once your body is you get a conscious awareness of your whole body, if you already put that body weight on your foot, then that information will be sent to the posterior parietal cortex, where that visual spatial body map is generated. So where is your body in space? So if you have to move your foot to the side, will you bump into the table, or can you safely put your foot to the side? So at each moment in time, your brain in that area will generate this visual spatial body map. And that will help create a plan to move, which is created in the prefrontal cortex. And then that plan is sent to your motor cortex areas to then actually do the movement and get your foot off that object. So what happens then with spinal cord injury? I presented here on the right, again, the information in a schematic way of what we just saw. And so what happens with the spinal cord injury is that the sensory information is now either altered or absent. And when that altered information comes up in the brain is not receiving what it expects to receive, and it gets confused. And because of that, because it doesn't get all the information it needs, it has a big problem in creating that body awareness and consequentially the visual spatial body map. And what we understood through this study as well is that probably the reason why neuropathic pain happens in half of the adults with spinal cord injury is that the brain is able to receive that sensory information, but because of the distortion, it has a harder time identifying what exactly that sensation is. And if it cannot label it exactly, it might label it as pain. And I will explain later why we think that that is one of the main reasons of why neuropathic pain occurs. So now I'm coming closer to how we have designed this study. Dr. Morse and Dr. Lindman in Harvard independently discovered that brain networks related to pain perception in adults with spinal cord injury and neuropathic pain were weaker compared to adults who don't have a spinal cord injury. And when I was talking to her about this, she mentioned that one of those networks was the parietal operculum network. And so we were talking about how could we restore these networks. And here is then where I could bring in my expertise, because I just published a study in stroke where I used this cognitive multisensory rehabilitation and showed that not only sensory motor function improved and remained improved over 1 year, but that the parietal operculum network actually restored, because that was also altered in stroke. And so from there came our idea to use CMR for adults with spinal cord injury and neuropathic pain, because in my study in stroke, only one person had shoulder pain, and that diminished with CMR. But there are other published studies, for example, in shoulder impingement, where they demonstrated that CMR also had good pain reduction effects. So the aims of our IRP study were to compare brain function in adults with and without spinal cord injury, and that is to validate Dr. Morse's earlier findings. And then also to look at the effect of CMR on brain function in adults with spinal cord injury and neuropathic pain. And then, of course, we were also interested in the behavioral outcomes of CMR on reducing neuropathic pain and improving sensory motor function. So then here I'll explain the methods of this study. So we aim to recruit 25 healthy adults without spinal cord injury, and then also 25 adults with spinal cord injury and neuropathic pain. And our objective was adults between 18 and 75 years old. And for spinal cord injury, at least 3 months after their spinal cord injury, and at least a 3 as a highest pain over the week. And you will see that the average highest pain was way higher than a 3. And then in terms of our design, the healthy adults were just doing a baseline assessment, so a brain imaging assessment and behavioral assessment, and that was just to have control data. And then our group of adults with spinal cord injury were randomized into one of two groups. So one group received CMR immediately, and it was 6 weeks, 3 times a week, 45 minutes per session, and it was a one-on-one physical therapy session in person. And then that group was scanned again, and assessments were done after those 6 weeks. And then we followed them up 6 weeks at home to see if improvements were maintained over those 6 weeks. The other group started with an observation period, so they were at home, did not receive therapy. We did also follow them weekly for pain levels. And then after those 6 weeks, they were tested again. And then after that 6 weeks of observation period, they also received CMR for 6 weeks. So in total, they had 3 assessment times. And the reason we set up this design is because we wanted to have a part that was a parallel randomized control where we had intervention versus control. So that is that first 6 weeks and how we analyze the data. But since those adults have debilitating pain, we also wanted to offer the therapy to the control group. So that's why they received the CMR afterwards. And that enabled us then to look at within group changes in the whole group for the CMR intervention. So then for our assessments, we did fMRI, and we had a resting state and then 5 tasks in the scanner. So one task was where we asked them to focus on their most painful body part in the scanner. The second task was where we asked them to feel into the body and imagine as if they were moving their most painful limb. So the left leg or the right leg. And we wrote down, of course, which one they imagined moving. And then the third task was to they watched a video of a whole body movement, which was a Qigong movement. So our arms and legs were moving. And we asked them to imagine in the scanner as if they were standing up and doing that whole body movement and how that would feel in the body. Then we also had a robot task where a robot was attached to the finger and they had to do shape discrimination. And then the last task is the one that I have some results about today because the rest is still being analyzed. And that is a sensory test. And so we used a towel to touch the pads of the thumbs and the toes, but we didn't tell them where we would touch them. And so I will explain more when we come to the results on that task. So those were the 5 fMRI tasks and a resting state. And then for behavioral assessments, we asked them weekly about the highest, most of the time, and lowest pain intensity that they had over that past week, what medication they were taking for neuropathic pain, if they used healthcare services during those weeks, and any self-report of community integration. And then at the 3 time points, we also asked them about the pain interference for mood, activity, and sleep. We also asked them about nociceptive pain. We did the Asia test for sensory motor function. We did a questionnaire on sci-fi. And then we also asked them, and that's a patient-specific functional scale, we asked them 3 activities that they could currently not do because of the pain, but that they would like to see improved if the pain goes down. So that could be sleep through the night without pain, or sitting in a wheelchair for a whole day and do some work without pain, or it could be any other hobby activity that would be very significant for them. And so those 3 activities were rated between 0 and 10, 0 not able to reach this goal, 10 able to reach this goal. And so we asked them their score, their self-reported score on those 3 time points. And then we had some secondary outcome measures that I won't report today just due to time limitations, but we looked at depression, anxiety, quality of life, self-efficacy, kinesiophobia, and body awareness. And so the statistical analysis that I will present today in graphs is between group differences. So that is that first 6-week period where we have the intervention versus the control, and also within group differences of pre-post CMR for the whole group of 26 adults. And then I will mention for group A, the 6 weeks follow-up, but I don't have any graphs today to show you, just to keep within my time limit. So here are the results. So these are the demographics. So we ended up recruiting 32 adults without spinal cord injury, among which were 22 women, an average age of 40 years old, and ranging between 21 and 69 years old. We also recruited 20 adults with spinal cord injury, 7 women, average age of 52 years old, and ranging between 25 and 74 years of age. And the time after spinal cord injury ranged between 1 and 56 years of age, with an average of 18 years post spinal cord injury. So they were all chronic. The highest neuropathic pain intensity over the week was almost an 8 out of 10 with a standard deviation of 1.44. So they were all with high pain levels when they started the study. You can see below also my graphs on the ASIA levels. So 15 had ASIA A, 3 had ASIA B, and 4 had ASIA C, and 4 ASIA D. And the spinal cord levels of injury were 5 cervicals, 17 thoracal, and 4 lumbar injuries. And so first, I will show you the brain imaging on the task of the sensory stimulation. And so to remind you the task, so we used a little towel to gently stimulate the pads of the thumbs and the big toes, but we only told them that we might touch the hands or the feet. We didn't tell them when we would touch them. And then after that scan was over, we'd ask them, what did they feel and where did they feel it? And so you see here again, I'm gonna turn my screen here a bit so you can see where my mouse is. So here you see again our brain regions that I explained earlier. So we expect that the stimulation will activate S1. And of course, that will be sent then to S2 or parietal operculum and insula. And you see on the right-hand side, the information about where the different parts of the body are represented in this primary somatosensory strip. And so the thumbs and the big toes are circled. Okay, so this is a result, a group result of healthy adults versus adults with spinal cord injury. And as expected, when we stimulated the thumbs, there was no difference between activation in healthy adults versus adults with spinal cord injury, because even though we had some people with quadriplegia, they were incomplete and all of them could feel the sensation of the thumbs. And so as you might know, and I'm gonna, turn it here. So if the right thumb is stimulated, if the left thumb is stimulated, the activation will be on the right side. If the right thumb is stimulated, the activation will be on the left side. And so the locations are similar in spinal cord injury and in healthy adults. And then also for the big toes, you can see that if the left toe is stimulated, the right toe is stimulated, then the left area will be activated here, because when you see the homunculus, the toe is a little bit inside of the brain. And then when the left toe is stimulated, it's activated on the right side. And because our participants could not feel the toe stimulation, we could also not feel or see any activation at the group level. However, we did confirm something that has been reported in literature before, and that is in some specific cases, even though they do not feel toe stimulation when we do that sensation task with the towel, some people still have activation in their brain. And that is what they call discomplete spinal cord injury. So even though behavioral tests show that they are not able to be consciously aware of that sensation, there is still stimulation seen in the brain. And so now the very exciting result that we saw, and of course, as I said, the brain imaging is still ongoing, but these are preliminary results, is that in some individual cases, we saw no activation of toe stimulation before and activation of toe stimulation after. And this was a right toe stimulation and corresponding with the left activation here. And to my knowledge, this is the first time that that has been reported in the, or yeah, first time that this finding has been shown, because I have not seen that published in any publication before. So I'm very excited about this. And so here's an example of another person, 65-year-old woman, C60H level of injury, Asia A, and 48 years post spinal cord injury. And I'm just going to go back to show you the previous one was 40-year-old man, 24 years post spinal cord injury with an Asia A on the L1 level of injury. So those were those people had spinal cord injuries a long time ago. And so you see that after those 6 weeks, which is only 18 sessions of CMR, we could demonstrate a return of activation in the brain on the primary somatosensory cortex, and in this case, also the secondary somatosensory cortex, indicated by S2. And then I will follow up with the behavioral data. So I will first start with the between comparison and then show you the within comparisons pre-post of the whole group. So here on the left side, you see in red the highest pain level intensity, and that's this line. This is the observation period, and so the pain did not change. The yellow is pain most of the time during the week, and the lowest pain experienced that week. Alternatively, in the group that received the therapy, the pain went down from 7.25 to 3.83, and then 5 to almost 2, and 1.8 to 0.5. So a marked difference with very significant differences between groups. And then for the next analysis of between group differences, we saw that group B, which were 14 people, the Asia tests for pinprick, light touch, and lower limb motor function did not change. However, in the group that did receive the CMR, they improved in sensation and they improved in motor function. And so those results were also significant. I did not show graphs here, but those results were similar in SCI questionnaires and also on those activities that they reported that were important for them. The change in score was 0 for the observation group and up to 5 points difference between before the therapy and after the therapy in their ability to reach their goal. And that was on a scale from 0 to 10. And then here are the within group differences. So this is the whole group of 26. And here you see that there is a marked reduction in pain overall from 7.81 to 3 for highest pain, from 5 to 1.3 for pain most of the time, and 2.62 to 0.3 for lowest pain. And so for the group that received the 6 weeks follow-up, those low scores remained. And I also have anecdotal evidence of participants reaching out to me 1 year later saying they still don't need any pain medication and the pain is still completely gone. So I just got IRB approval to reach back to this group to see and actually assess that 1 year follow-up. And so of the 26, 9 participants were completely pain-free after the study. So that's 35% of our sample. And then similarly, when we looked at the whole group before and after for Asia testing, there was a marked improvement in sensation for pinprick and light touch, and also for lower limb motor function. And similar results were seen for the SCI questionnaire and also for those activities where they also improved almost 6 points on their ability to reach their goal between 0 and 10. And then I also wanted to show you the results on the INDS-CDE. So there is a marked reduction on pain interference for activity, mood, and sleep. We already know that neuropathic pain went down very significantly, but also nociceptive pain went down significantly. And so for the last part of my presentation, I would like to go over the CMR assessment. So I have some videos of assessments, so sit to stand or walking before and after therapy, as well as one explanation of an exercise so that you have more information about what is the content of the CMR. And so here is a quick overview. I won't go into this in detail, but just to explain to you the reasoning of this therapy. So first, as I think in other therapies, the PT will observe actions of the participant, and maybe different than other therapies, she will also listen very intently to how the person is perceiving the action and how he or she is describing the action because that will also help them find strategies to help this person regain that awareness of the body in space. And so she will, in this case, Sarah chose a reference action, sitting to standing, identifying what was going on, where possibly there were problems in body awareness, devising then an exercise to treat that, seeing if that has the right results with the right strategy, using that for therapy, and then evaluating the action again at the end. And so, of course, there are multiple exercises that can be used, but the main goal is really to regain that awareness of the different body parts and the body in space using the hand or using other textures or sponges. So it's not, again, it's not about the discrimination per se. It's really finding a strategy of using the body to regain that awareness of the body in space. To conclude then, as I showed you, we could demonstrate with the fMRI that there is sometimes some residual somatosensory brain activation in some adults with spinal cord injury, even if they don't consciously feel the sensation in the toes. With training body awareness with CMR, we have demonstrated, at least in some participants so far, improved brain function, and those analyses are still ongoing. And we did show that training body awareness with CMR leads to neuropathic pain reduction and functional sensorimotor recovery. So in sum, this study shows promising results in neuropathic pain reduction, as well as improvement in brain function, sensation, movement, and function after 6 weeks of CMR, remaining at the 6 weeks follow-up and possibly longer, up to a year. So that concludes my talk, and thank you to my team who made this all happen, and thank you very much for your attention.
Thank you so much, Anne, for such an excellent presentation. And as people are beginning to type their questions into the Q&A box or the chat, I'd like to introduce our discussant for today, who is Joe Daly. So Joe was in a motor vehicle accident in November 2002 that resulted in a C5, C6 spinal cord injury with tetraplegia. Prior to his injury, he was employed as a project control specialist for Mortensen and is currently a community stewardship coordinator for the company. Having been a marathon runner, he remains committed to fitness, working out at the Courage Kenny Fitness Center, practicing adaptive yoga, participating in the ABLE program in the past, and enjoys hand cycling and skydiving. He is a co-founder and executive director of Get Up, Stand Up to Cure for Paralysis Foundation and has been accepted to the Minnesota Statewide Independent Living Council. Joe, thank you for being here.
Thanks, Kim, for that introduction, and thanks, Anne, for a great presentation and for allowing me to be part of your study. So I want to give just a little bit of background information regarding my experience with neuropathic pain. And I first started experiencing that when I was in intensive care right after my injury. And it sounds insignificant, but that neuropathic pain was in the end of my left index finger. And when I reported that pain to the medical community, if you will, at that time, it was pretty much dismissed, and they really didn't do a lot for it. And I did not experience any other neuropathic pain until 4 years post-injury. And that neuropathic pain started in my ankles, more so in the left ankle than in the right ankle. And again, I sought medical advice and went and saw a neurologist. And I was basically told that it was phantom pain. And I was put on medication that the medication pretty much put me to sleep. So it didn't really do anything for the pain, it just put me to sleep. So then fast forward, and I got involved with the study, with Ann's study. And the first thing that really was eye-opening to me was the acknowledgement that my pain was real. And the acknowledgement that instead of giving me medication to alleviate the pain, the idea was to let's figure out what's causing the pain and how we can eliminate it through exercise and through knowing where my body is in space. And those things were very eye-opening. You know, as you watched in the videos, I experienced that as well. You know, in the beginning, not knowing which foot was higher or lower or where I was being touched. And at the end of the study, how much that changed. And the other part of it also was we didn't spend a whole lot of time. Actually, we spent about 15 minutes in the entire study addressing the neuropathic pain in my left index finger, where Sarah worked with me on figuring out where my finger was in space. And I learned in that session, if I just made contact with another part of my body while there was pain in that finger, the pain was immediately gone. So I very seldom experience neuropathic pain in that finger anymore. Similarly with the pain in the ankles, that has improved dramatically as well. Or just knowing where my body is in space or making a connection with that really alleviates that neuropathic pain. If I can, I'm going to share my screen for a moment. This was eye-opening to me as well. My final Asia results in the study. So if you can see that, I think it's dramatic what the difference was in my Asia scale and the touch prior to the study and afterwards. So that's what I have to share. And again, thank you everyone for attending. Thank you, Anne, for letting me be part of the study and for letting me be here today.
Thank you so much, Joe. It's fascinating to hear your experience, and thank you for being willing to share with everybody. So, Anne, we have a few questions. One in the chat, one in the Q&A. I'll start with the first one. So, Barry Weintraub had asked, so when the brain analyzes neuropathic pain as some sensory input, are you suggesting that the brain may be confused on the information it is receiving? Following that, is it more important to figure out what the actual stimulation is, identify the issue, and treat or work to better the issue, and that should alleviate the pain?
Yes, that's exactly what we do with the CMR. So, and that's what I see consistently. So over the 6 weeks, participants reduced their pain at different point in time, but every time it was the moment that they could feel where the legs were in space or could identify that it was pressure or texture correctly. The moment that that happened was when the pain went down and when the spasms went down. So that's why I'm more and more confident that that is what drives the neuropathic pain, is that sensations, whether it's position sense or texture or anything else or pressure, that is not, that the brain is not able to correctly label it, and that it then just for sake of survival labels it as pain. And the moment that the brain then realizes, no, it's not pain, it's actually pressure, or it's my hand touching my foot or something, then those symptoms went away. As Joe was mentioning too, when he touched with his finger another part, the brain could identify that that was a touch. The key really in the therapy is to find the right strategy to help people recover that body awareness. It's not just simply asking them, is it higher or left or lower? No, it's wrong, do again. That's not what gets the result. It's really finding that alley, that right strategy of regaining that awareness of the body in space.
Thank you, Anne. Somebody also asked for your email in the Q&A, and I provided it. So
Thank you.
I hope you don't mind. I figured you wouldn't. And then we have another question about knowledge translation and implementation. So some people are very eager to understand knowledge translation for us as acute and early outpatient therapists, and any direction on how to learn more about implementing CMR principles in current clinical care would be greatly appreciated.
Well, then you're going to be happy with my answer. So we already provided an introduction course in the fall, and I mean, we intend to continue that, and also, of course, go for NIH and DoD grants where that part is also implemented. So the goal is to organize another introduction class with CMEs later this spring, and then to do a longer class for a first level if you want in the summer. So I'm organizing that as we speak.
And so you're offering that in the Minnesota area, in the Minneapolis area?
Yes, at the university.
Okay.
And so because the therapy is taught as a 2-year course in Italy, but we are bringing the knowledge here through several courses in collaboration with them. And so that is how we are setting it up. So I will definitely let you know when things are in place so that you can register and start learning about this therapy as we go.
So we're not taking a group trip to Italy?
You always can take a group trip, but I'm also offering a less travel intensive one.
Somebody also had a question if the class or the training would be open to non-therapists.
Ideally, we would like to do it for PTs and OTs, just because we are not covering the background of every, physical therapy approaches in that sense. Of course, if there are caregivers who would like to know more, this can be discussed on a case-by-case basis.
What about researchers?
Yes, that would be also, of course,
okay.
An option. But I'm just saying that the classes are built into people who have a PT or an OT background. So just to keep that in mind.
All right. Would you mind sharing that last slide for me?
Absolutely.
In the
Yes. I haven't shared my screen yet, so I'm going to do that right now.
We want to thank everybody for attending today's Grand Rounds, and the recording of the webinar will be posted soon on our website, which will come up on the slide shortly. And as a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar. And at the end of the webinar, you'll see a brief 3-question survey that will pop up on your screen. We would appreciate any feedback you have so that we can improve on our Grand Rounds. And we also hope that you can join us for our next Grand Rounds, which will be on Thursday, May 5th at noon Central Time. And Dr. Peter Grahn from the Mayo Clinic will present. The title of his presentation will be Ongoing Studies of Mechanistic and Translational Spinal Stimulation for Motor Recoveries in Individuals with SCI. And so here's that slide that has our website address, as well as our Twitter handle. Feel free to follow us on Twitter if you're on there, and then information about our next Grand Rounds in May. And we want to thank you again for attending, and thank you, Anne, for a great presentation.
Thank you very much. And thank you, Joe, too, for sharing.
Yes, thank you, Joe.